just across the patients your organization supports, where do you see the most common breakdowns in their diagnostic journey?
I think it starts with testing. I think it takes a long time. I think the data is 7 or 8 years and up to 10 specialists before they get an accurate diagnosis. And what we hear from patients in terms of like their anecdotal stories is that it takes them a long time to get a physician to even test them for this. It's usually once they finally get to an allergist, that's when maybe they get the testing. But a lot of times they're first they're going to the ER or they're going to their family physician and they're just saying something's not right. And there's so many things in the differential diagnosis that have to be kind of worked through. And so sometimes it takes a long time before they get the testing appropriate. And then additionally, sometimes our community physicians that don't see this a lot or aren't experts in this, they don't really know what the testing is supposed to show. So for example, I can't even tell you how many patients tell me that they have been tested for their serum tryptase has been tested and it was elevated, but because it wasn't high enough, they were told there's no way they could have systemic mastocytosis, which is not true. But it's complicated this might be the first patient you've ever even tested for systemic mastocytosis. You've maybe never seen it in your practice. And so there just needs to be a lot more education and awareness around what the tests are, what the results mean, how to do the testing properly. We also hear a lot from patients that they have to do repeat tests if specimen aren't stained properly and things like that. And that can really slow down the diagnostic journey because you might get a negative test result and then it's like another 4 years before someone tests you again. And it turns out you actually were positive for mastocytosis.
Such a great point, Jessica. So great. I 100% agree with her. And people don't understand that, for example, recent studies, there's a Pioneer study in which many of those patients treated with systemic mastocytosis that actually had a mutation that proved that they had systemic mastocytosis plus bone marrow biopsies, that their baseline tryptase was really in the normal level. And we're talking about even as low as 5, which is super normal. And when we see that, we're like, there's no way you can have systemic mastocytosis. And so, yes, the tryptase range can be quite broad. And I think that even so, before this recent generation, those tests for the genetic mutation that drives a mast cell to grow or reproduce, the most common genetic mutation, was not that well detected until recent tests. So we have much better tests now. Doctors have to use a newer generation of testing. And then and certain companies are now even developing an even more sensitive test. So I think that technology is helping us to catch up with that diagnostic deficit in the past. Yeah.
And let's talk about those tests specifically. Let's say, on the patient journey, a person suspects that they might have, systemic mastocytosis, and maybe they've been to a rheumatologist, maybe they've got these negative tests. I'm interested if a patient wants to advocate for themselves, what tests should they specifically ask for? And just to tack onto that while you're thinking about that, are there over-the-counter things? Because when I think about things like chronic hives, I think about, taking, antihistamine all the time just before you figure out, hey, I probably shouldn't be taking it this much. Are there things that people do over the counter or in their day-to-day life that could skew the results of these tests? After you tell me what tests they should be asking for.
Yeah, the most specific test, of course, Jessica already alluded, the first screening test would be a tryptase. And certainly there are other mediators, markers, other chemicals that we could test for. They may be variable, however, which may include things like histamine or urinary prostaglandins or urinary leukotriene. Some of these are challenging to find at a hospital. There can be a whole panel of tests you can order, including, urine methylhistamine. I'll just throw them out there and then people can consider whether or not they want to order them. Those, again, can be quite variable. For GI symptoms, sometimes we order, for example, chromogranin A. But really, the tryptase being important, the tryptase when somebody's having a reaction, an attack, an anaphylaxis, really helpful. It is within 4 hours, so it could be less than 4 hours. This chemical kind of starts to peter away in the system. So as soon as they have the reaction, they really need to get that blood drawn, which is sometimes a challenge for patients, especially if they're having reactions in the middle of the night. So that's really helpful to see that change or rise. So even if you have a baseline that's like 8, if now all of a sudden you're having a reaction, it's 16. And I have had those patients, totally normal baseline of 8. And then when he had anaphylaxis, it was 40. I mean, we are talking about flagrant change. And so really, really helpful. And then the second generation of testing, the next step is to get a D816V mutation testing. That is not the end all and be all. People can have other mutations in terms of that KIT production, which that is a mutation in which there's a substitution of amino acid, and it's a turn on substitution, which means that now the cell can't stop reproducing. It's like really crazy. It wants to just keep making more. And so that turn on switch is caused by that specific mutation. But there are other mutations that can turn on, of course, this mast cell. That just happens to be the most common one. And we have a nice simple blood test for that. It's a screening test. We call it c-KIT, D816V mutation. It's a simple genetic blood test, one mutation, covered by insurance. And so really helpful to try to get that test if you strongly suspect a patient has systemic mastocytosis, even in the light of a normal tryptase.